Hello everyone. Today we are going to see the same topic, that is global malabsorption. We were discussing three diseases. First is the celiac disease, second is the Whipple's disease, and third is the tropical sprue. Yesterday we finished celiac disease, but now we will be continuing with the Whipple's disease. So what is Whipple's disease? Whipple's disease is basically a multi-system disorder caused due to the damage of the small intestinal mucosal layer, and this damage is caused with the help of an organism which is a gram-positive actinobacteria, Trophema whipple. This Trophema whipple is responsible for damaging the mucosal layer and thus affecting this global malabsorption. So this is a chronic multi-system involvement, like joints are involved here, GIT is involved, CNS is involved, CVS is involved. It occurs majoritarily in men as compared to female, and the age at which it is very common is the age from 50 to 60 years. Majorly, the damage will take part in proximal part, then the distal part, and this actinobacteria I told it is gram positive and it is also called as actinobacteria. The immune susceptibility is for the marker present on the gene are HLA-DR B13. This is the first marker, and second is DQ8104. And for diagnosis, what we will prescribe for diagnosis? We will always tell that the patient should do biopsy. Biopsy gives the confirmatory test for Whipple's disease. So, in which other conditions does this biopsy help? This biopsy also helps in A beta lipoproteinemia and A gamma globulinemia. And here we will be moving on to the clinical features. What are the clinical features of Whipple's disease? Whipple's disease is majorly going to affect the four systems. First is the joints, second is the CVS, third is the GIT, fourth is the neural system. So in joints, in 80% cases, more than 80% cases, large joints are affected, such as the joints of knees. And it also produces migratory arthritis, alengia, and migratory arthritis. Majoritarily, it will give migratory arthralgia, and it will also give migratory arthritis. In GIT, after the symptoms of this joint, for 2 to 3 years, there will be consecutive flushing of stool. There will be occurrence of diarrhea, weight loss, abdominal pain with mesenteric lymphedema, lymphadenopathy, with mesenteric lymphadenopathy. This will occur for 2 to 3 years after the features were occurring there. So first the joint are affected, then the GIT is affected. Now it will go to neural thing. So in neural pathway, it is called as neurovipilis. Here, first symptom which will cause it dementia, rapidly progressive dementia. This is the most common. Then the second most common is oculomasticatory myarrhythmias. Oculomasticatory myarrhythmias. Like the patient will start chewing anytime. Even though the food is not inside his mouth, he will he will start the acting of chewing. That is oculomasticatory myarrhythmias and oculofacial myarrhythmias. Like he will make facial expressions whenever they are not needed. Still, he is making facial expressions subconsciously. He is also unaware of that thing. So that is oculofacial myarrhythmias. They are associated with the supranuclear ophthalmoplegia. That's the factual point. The oculomasticatory myarrhythmias, and it is also present along with the pendular nystagmus. What is pendular nystagmus? In pendular nystagmus, like you can see, you have two eyes. If you are looking at left, your right, sorry, if you are looking at right, your right eye will move first, and then it will followed by the left eye. So the first right eye will reach the destination, then the left eye will reach the destination. But in this pendular nystagmus, both eyes will move with the same speed. Like if you will see right, both will move with the same speed, and it will show a pendulum like appearance. Like pendulum has to and fro motion. That is pendular nystagmus. Mastatory arrhythmia, as I told you, that the patient will start feeling even though the food is not there, and he's subconsciously doing that. He's also unaware of that thing. Relapse associated with CNS manifestation, bad prognosis. If the maintenance dose is not maintained after you give the drug, after the disease is cured, still the patient is getting the same disease again. That is called as relapse, and it is due to bad prognosis. Like if you are not giving the proper drug to maintain the neurological disorder, it will return, it will get relapse. So that is due to bad prognosis. In serious, culture negative endocarditis. What is culture negative endocarditis? If you see the endocardium, you will see infection there. But when you will try to grow that infection inside a petri dish along with the nutrient, the bacteria are not growing there. So you will suspect that there is no infection, but you can see that there is infection and the bacteria are hidden. So they are called as ghost bacteria, they are hidden. That is culture negative endocarditis. What is culture positive? If you can see the infection and you can grow that infection inside the petri dish, you can grow the microorganism inside the petri dish, then it is culture positive endocarditis. But in culture negative, the microorganism are unable to grow. It will majorly happen on mitral valve, then the myocarditis, and then the pericarditis. It will first affect the mitral valve, then it will affect the myocardium, and then it will affect the pericardium. So, culture negative endocarditis, this is the trick, HACEK, and these are the organisms. You can read it just. That's it. After seeing the Hake organisms, we are going to the Whipple's tetrad. What is Whipple's tetrad? Here, the major symptoms of the Whipple's disease can be seen. That is the Whipple's tetrad. So, first is the joint symptoms. You will see joint pain, migratory arthritis, and all. And you will see diarrhea, that is stomach related issues. You will see weight loss, and you will see abdominal pain with mesenteric lymphadenopathy. Differential diagnosis. In joint symptoms, if you see spondyloarthritis, then that is also a diagnostic test. And in GIT, if you see TB, then also you can predict that this patient might be suffering with the Wilson's disease. So, if these two symptoms are appearing, the first thing you should do is biopsy. As we all know that if we are suspecting that there is a Whipple's disease, you should do the biopsy. Biopsy is the diagnostic test for identifying the Whipple's disease, like it is written here, biopsy. If you do the biopsy, you will get to know if the patient is suffering with this or not. In diagnosis, upper GI endoscopy, investigation of choice is biopsy, as I have told you. And after biopsy, if you are still unable to find it, you can move to PCR. PCR will identify this Whipple. That's all the diagnostic test. Then we'll move on to the treatment. In treatment, what you will give? You will give IV ceftriaxone. IV ceftriaxone. For what is the dosage? You will give 2 gram of ceftriaxone for 14 days. It is the best choice of drug for this, and you can give along with penicillin and streptomycin. Majority of the drug which is used in India is the streptomycin only for this Whipple's disease, and the maintenance dose is cotrimoxazole. This cotrimoxazole is used as maintenance dose to prevent the relapse if there is any neural disorder, like neural manifestations will be there obviously. What will be the neural manifestation? The patient will suffer with a dementia. So it should not get relapse. We should give the maintenance dose to the patient, that is cotrimoxazole, to prevent the relapse. And why does it is able to prevent the relapse? Because it has good CNS penetration, that it can cross the blood-brain barrier. If it is able to cross the blood-brain barrier, it can act on the right receptors and can prevent the relapse. Okay, in biopsy, okay, you have done the biopsy of a Whipple's disease patient, but what should you see inside that biopsy? What should you see? You should see PAS positive foamy macrophages like structure in the epithelium of lamina propria and submucosa. If you are able to see this pink color spot, it will be like pink color spot dot 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 there. That is pass positive foamy macrophages, and it should be on the epithelium and the lamina propria and the submucosa. If you can see this, you will suspect that the patient is suffering with Whipple's disease. And if he has the symptoms like joint symptoms like spondyloarthritis or GI symptoms like TB, then you can sure say that the patient is suffering with the Whipple's disease. And that's all about Whipple's disease. Now we are moving to tropical sprue. Tropical sprue, it is a disease in which the malabsorption gets activated. There is global malabsorption. It is majorly found in the people of India, Bangladesh, and Pakistan. Histological features are similar to celiac disease. What are the histological features of the celiac disease? That you will see villus atrophy, and crypt hyperplasia. Crypt hyperplasia. What is the pathophysiology of this tropical sphere? First, the patient will get infection of diarrhea with the help of in the presence of this toxigenic coliforms such as E. coli and Klebsiella. Whenever the E. coli and Klebsiella they are abundantly found in these regions, India, Bangladesh, and Pakistan, they will come inside the gut and they will start releasing toxins. We know that our gut contains carbohydrates, so this unbroken down carbohydrates, what these organisms will do, they will go to the carbohydrate and they will start fermenting the carbohydrate. After fermentation, the carbohydrate will release alcohol, ethanol. You can see fermentation product, majority product is ethanol. Now the ethanol is released. After that, this bacteria never stops. It will go and try to damage the small intestinal wall, like structural damage to the small intestine. This is the only reason we are able to see this atrophy and the crypt hyperplasia, because there is damage to the small intestinal wall. After the damage, it will impair absorption of folic acid. If it's less than 2 to 3 weeks, it is called as pan-intestinal involvement. It will go into pan-intestinal involvement. And if the small intestinal structure are damaged, not only the folic acid, but there will be defect in vitamin B12 absorption, bile acid absorption, magnesium absorption. These are all the clinical features. And if there is defect in B12 absorption, you know what you will see. You will see hyperpigmentation on the skin. Hyperpigmentation. If bile acids are not absorbed properly, what you will see? You will see osmotic diarrhea, because these bile acids are responsible for breaking down the fats inside the small intestine, but they are only not coming there. So fat will go and retain there, and they will form soap, and they will drain water and electrolytes from the small intestine. So it is there will be deficiency in magnesium. Magnesium is a vital mineral required inside the body. And you can see, as I have told, same clinical features you will get. But don't just mug it up. You should correlate the things. How you will correlate the things? Like you saw here that bile acids are not getting absorbed. So clinically you can think that he is suffering with osmotic diarrhea because bile acids are responsible for breaking down of fat, and fat is not getting breaking down. So the person will suffer with diarrhea, volumetry, watery volumetry diarrhea, because it drains water and electrolytes from the small intestine. Then you can see steatorrhea. Steatorrhea is the hallmark of fat malabsorption. As I have told you, fat is not broken down by bile acid, so it will get malabsorbed, and you can probably say that the patient might have been suffering with steatorrhea. If there is diarrhea, for sure there will be weight loss. That's the majority of case. Folic acid will be deficient. Most prominently, we diagnose with the help of folic acid only. Folic acid is deficient, we will move for the further diagnosis. And hyperpigmentation, I told you, if vitamin B12 is absent, it will show on your skin. It will show on your skin with the presentation of hyperpigmentation. What are the investigations? If you took the biopsy in tropical sphere, you will find the same thing that you find in the celiac disease. You will find villous atrophy and you will find crypt hyperplasia. But the serology in this case is negative. The serology in celiac disease is positive. If the serology is positive, the patient might have been suffering with the celiac disease, but here the serology is negative. But biopsy here shows the same clinical manifestation as it has shown in the celiac disease. So stool examination, why is the stool examination done? For seeing if the OI is containing cyst or trophozoite condition is present inside the ovaries. So for that we can take a stool test. And what is the treatment for tropical sphere? First of all, the most prominent feature here is deficiency of folic acid. The first thing we should be doing is injecting folic acid inside the patient. So 5 mg of folic acid is given along with the tetracycline, 250 mg of tetracycline. Why we give tetracycline? Because this tropical fever was caused by two toxogenic coliforms. The two toxogenic coliforms are E. coli and Klebsiella. For killing this bacteria, we need a tetracycline. This is a type of antibiotic. And after giving tetracycline for 3 to 6 months, the patient gets cured. Note point. So this is just a factual point. Relapse in 20% cases. In 20% cases, you will get relapse after giving the maintenance dose as well. And in SIBO, now the small intestinal mucosal layer is damaged. So these organisms will start growing there. So organisms will come and use B12 and synthesizes folic acid there. That is all about the tropical sphere. Then we are moving on to bile acid diarrhea. What is bile acid diarrhea? Whenever the bile acid are unabsorbed, this bile acid will move from the small intestinal tract to the colon. And in colon, it will start withdrawing electrolytes as well as water inside the colon and it will induce this bile acid diarrhea. For preventing this, what we will give bile acid raisins. That is another topic that I'll be telling you, and we have already learned this in pharmacology. So it is also known as bile acid diarrhea, is also known as cholera. It is seen in tropical sphere due to defect in FGF19. FGF19 is a peptide hormone. Just remember it. In ileal enterocyte. And what does this peptide hormone basically does? It will tell the gallbladder that when should you produce the bile, when should you release the bile inside the duodenum, and when should you stop releasing the bile. So in this bile acid diarrhea, there will be defect of FGF19 hormone. When it is present in the ileal enterocytes will produce this FGF19. They will go sensory to liver and they will produce the appropriate amount of bile acid. But what will happen here? There is defect in the FGF19. Now the bile acid release in the ileum will decrease. Now we have moved on to the limited iliac disease. There are two types of iliac diseases. First is the limited iliac disease and second is the severe iliac disease. So what is the limited iliac disease? When the ileum is affected, when the ileum is recessed or dissected, it is removed from the intestine or it has malfunctioned. So this limited iliac disease occurs. If the intestine is severely damaged, then the severe iliac diseases occur. Here what happens, the FGF19 gene is limited. So this gene will tell the liver that produce more bile and the liver will produce bile. But there is defect in this in ileum. So ileum is unable to absorb 100%, 95% of the bile acid. It will just absorb sometimes 70%, 80%, but other 10-15% is left alone. So this 10-15% will move from the small intestine to the colon. And in colon, they will start withdrawing electrolytes and water from the colon and it will lead to bile acid diarrhea. The same thing is written here. Any ileal disease, FGF19 is positive in limited quantity. Liver produces bile as a compensatory mechanism because this FGF gene will go and tell the liver again and again that we need more bile for the digestion, for the breakdown of fat. But liver is also unable to compensate this thing because it is also getting overworked because 95% should be getting absorbed, only 70% is getting absorbed, and rest of is getting wasted in the stool. But the bile will go inside the colon and it will start removing sodium, calcium, potassium from the intestinal epithelium. And we know the rule of osmosis, if the ions are moving, water will move along with them and it will lead to bile acid diarrhea. There will be no steatorrhea, no malabsorption in this because liver is producing more and more bile, and the fat present in the small intestine will be broken down into pieces as the compensatory mechanism done by the liver. Hats off to liver about that. Then there is severe ileal disease. In severe ileal disease, the small intestine, the ileum, is completely damaged, and there is no reabsorption of bile acid. And liver is like it is. It also has its limit. It will not produce all the bile every time, and you also require this FGF19 protein, or you can say hormone. If it is not present, so how you will produce it? Small intestine is not there, so FGF19 hormone is not there, and bile is not produced, and bile will move outside. So here you will see that the fat is not broken down into pieces. If the fat is not broken down, it will majorly lead to steatorrhea. As you can see here, severe ileal disease, there is reabsorption of bile, very less reabsorption of bile or no reabsorption of bile. So as there will be no compensatory mechanism because FGF19 gene or 19 hormone, not gene, it is hormone only. This hormone will be in limited quantity, will be present in limited quantity, and if the ileum is like damaged, so why does this hormone will get released and all? So the malabsorption will occur here. Fatty acids will be there in colon and it will lead to steatorrhea. If it is more than 20 grams, then it will lead to steatorrhea. And that's it about the ileal disease. Now we are going to compare the bile acid diarrhea and fatty acid diarrhea. First is ileum bile acid absorption. In bile acid diarrhea, there will be less bile acid absorption as the small intestine is damaged, as the ileum is damaged. So there will be less reabsorption. If there is no bile absorbed, you can say it will affect the fatty acid diarrhea as well. There is less reabsorption, less fatty acid diarrhea, less bile acid absorption due to this fatty acid diarrhea. Fecal bile acid excretion. It will increase in bile acid diarrhea because there is no reabsorption. It will also increasing in fatty acid diarrhea. Bile acid pool size. Here the bile acid pool size is normal because the liver is again and again doing compensatory mechanism to make the ratio of the bile acid in proper position. But in fatty acid diarrhea, it will go on decreasing and decreasing. Intraduodenal bile acid, it is also normal because liver is giving the compensatory mechanism, same reason. And here it will decrease because of the same reason that it is getting flushed out and the liver is unable to produce that amount of bile inside this diarrhea. Response to cholesterol. Cholesterol, yes, bile acid diarrhea will give a positive response, but it will not give fatty acid diarrhea. In fatty acid diarrhea, if you will reduce the percentage of fat consumption, then it will respond. And in bile acid diarrhea, if there is low fat diet, it will not respond. Will not respond. And cholesterol, it is a drug of bile acid resin. In a category of bile acid resins, it will go and bind to the negative charge of the bile acid and it will stop the enforcement of sodium, potassium, and chloride, which is released from the colon into the lumen along with the water, and hence it will help in stopping the diarrhea. In bile acid diarrhea, it will not be applicable for fatty acid diarrhea. And that's the comparison. Now we are moving on to short bowel syndrome. What is short bowel syndrome? Here you will see the length of the bowel is short. It is less than 200 centimeter. If the bowel length is less than 200 centimeter, we can say that the patient is suffering with short bowel syndrome. Very severely short bowel syndrome, if the patient has less than 100 centimeter of the bowel length, then it is severe short bowel syndrome. How does it occur in adults? How does it occur in children? In adults, it will occur due to mesenteric vascular diseases such as ischemia of bowel or recession, means we have cut the bowel into pieces and then it is rejoined. And the third reason is the Crohn's disease. In these three diseases, the adult can get short bowel syndrome. And what about the children? Necrotizing enterocolitis. In this condition, the pediatric child will suffer with short bowel syndrome. Apart from that, what are the clinical representations of the short bowel syndrome? Okay, you have less bowel. So, majoritarily the part of the small intestine, which is the ileum, it is getting removed. And you know, ileum is very necessary for the absorption of oxalate. But what is happening here? Here, fat is coming there, and fat is getting bind with the calcium, and oxalate are unable to absorb, and it will lead to hyperoxaluria. Oxide, this oxalate are unable to absorb inside the small intestine. They will move for defecation, and in colon will say, okay, I can absorb you, and colon will absorb the oxide, and it will move inside the blood. The blood system will get panicked that this is an excretory product. Why are you keeping this inside the blood? The blood will send this to kidney, and in kidney, this oxalate will find calcium, and it will form oxalate stones there, calcium oxalate stones. And you can see this oxalate in urine. If it does not find calcium inside the kidney, it will still get excreted out. So, absent of a proximal small intestine, there will be an absorption of long chain of fatty acid. Long chain of fatty acid will bind with the calcium and oxalate becomes soluble. As this is the same story that I have told you, that there will be absence of small intestine, and then there will be unabsorbed long chain fatty acid because the bile salt didn't came there, and it does not get the full time to stop and get broken down into pieces. These fatty acid will go and bind the calcium, and it will form soaps, and this process is known as saponification. This long chain of fatty acid it will bind to calcium, and this process is called saponification. Soap will be formed. When oxalate will come there, oxalate will be unable to see calcium single. It will see that the calcium is already found, so it will move on to the colon for excretion. But in colon, the oxalate will become soluble, and when it will go inside the blood will get panic. It will send it to the kidneys, and in kidneys it will bind to the stones, and it will form. It will bind to the calcium, and it will form calcium oxalate stones, and this oxalate stones in the urine will be released. Sometimes it will be releasing, sometimes it will be staying inside the kidneys, and it is a very painful process to remove them. Then we are moving to the second clinical manifestation, that is cholesterol gallstones. This cholesterol gallstones they will form in the absence of ileum because the bile acid is staying retained inside the gallbladder, and it will lead to the formation of stones, and vitamin B12 is not absorbed, so supersaturation will be there, hyperpigmentation will be there. In the skin, you can see the clinical manifestation here as well. Third is the delactate acidosis. This is delactate whenever the carbohydrates are present inside the small intestine. Some bacteria will come and start fermenting the carbohydrate, and one byproduct that will be created by this microorganisms is delactate, and this delactate can get absorbed inside the brain and get stored there. So it will show some neurological manifestations as well. So this delactate acidosis will be caused in short bowel syndrome or small bowel syndrome. This physiology, we'll see what was the basic physiology. This lactate, L-lactate was formed, flora of the colon, bacteroids, fragilis. In pathology, impaired digestion of carbohydrate inside the colon, excessive fermentation by gram-positive anaerobic bacteria. The pH of the colon lumen will be decreasing. This bacteria will overgrow which bacteria? This lactobacillus and bifidobacterium, and this will convert this L-lactate to D-lactate, and D-lactate will be absorbed into the blood, and this D-lactate will cause acidosis inside the CNS that will cause CNS manifestations there. This is the third clinical feature of short bowel syndrome. And fourth is hypergastrinemia, absence of small bowel. There will be decreasing in the intestinal hormone, and gastrin will be uninhibited. There will be secretion of gastrin in a large amount because these intestinal hormones are absent. Gastric inhibitory peptidase. This hormone is majoritarily secreted by the ileum, but the ileum is short. This hormone is secreted in a very less quantity, and this gastrin inhibitory peptide is not inhibited. So it will lead to hypergastrinemia and hypomagnesemia because there is less ileum. So this magnesium is not getting absorbed. This is just a basic thing. Gastric emptying, defective iliac brake if there is iliac brake. Physiologically, what is happening? Increasing in unabsorption of fat enters the intestine, this small intestine in the ileum. GLP-1, GLP-2, these are peptide hormones which are responsible for decreasing the motility and decreasing the gastric emptying. Basically, what was happening in gastric emptying, I will tell you in a very simple language. There is defective ileal brake here. So, the fat which is entered in the lumen, this GLP-1 and GLP-2 are responsible for decreasing the motility. But when they will decrease the motility, when the food will come inside the gut and it will hit the intestinal walls, it will hit the small intestinal ileum walls. So this ileum will secrete this GLP-1 and GLP-2. But now the ileum is defective. The ileum is malfunctioned. It will not be able to secrete the GLP-1 and GLP-2 hormone. And if this hormone is not secreted, there will be no inhibition in the motility. The motility is not decreasing, and there will be rapid stool passage, and it is called as gastric emptying. And your stomach will get empty fast. Seventh is deficiencies. You will see various calcium, uh, iron, and vitamin deficiency. If iron is absent in duodenum, mostly it is getting absorbed, but it is absent. So this calcium, this iron absorption is hampered. Then the calcium, folate, vitamin A, D, E, because of the absence of jejunum, these are also getting affected. Vitamin K, it is rarely synthesized. Absent in the absence of the ileocecal valve, then there will be migration of bacteria, and this migration of bacteria inside the duodenum and this jejunum, it will lead to this SIBO, small intestinal bacterial overgrowth. Due to the loss of the ileocecal valve, this valve was basically controlling the ileocecal microorganisms to not being entering into the ileum and further moving to jejunum and duodenum, but due to the loss of this ileocecal valve. Why does this ileocecal valve get lost? This is got lost due to cutting of the small intestine. It might be due to any reasons that we have seen previously. It might be in adult or children due to their own personal reasons. Then we are moving to the management of this short bowel syndrome. What you will do to manage this short bowel syndrome? You will feed the patient with medium chain fatty acid. You will not give long chain fatty acid because for breaking down of this long chain fatty acid, you will require bile and you will require a lot of time that this long chain of fatty acid should stay inside the small intestine. But there is defect in the small intestine. It is not defect, but the small intestine is very short. So it won't be staying there and it won't be getting breakdown and it will lead to diarrhea. But for medium chain fatty acids, no, medium chain fatty acids, it will directly get absorbed inside the small intestine, inside the lacteal. But there is no need for breaking this medium chain of fatty acid and stop feeding the patient with long chain of fatty acid. Complex carbohydrate, it can be given, it is absorbed in the colon And you can also give short chain of fatty acid. If you can give medium chain of fatty acid, so it also means that you can give short chain of fatty acid logically. And protein, you should be giving protein as per this data, 1 gram 1 kg per day. You first of all you should measure the weight of the person. If the patient is measured 60 kgs, for example, so you should give 60 gram of proteins per day, and that's it for the diet management of this short bowel syndrome. If the colon is absent, we don't know in short bowel syndrome which part is absent. Sometimes duodenum may get absent, sometimes ileum may get absent, sometimes colon may get absent. So if the colon is absent, there will be total parenteral nutrition required. Everything from magnesium, from calcium, everything you should be given parenterally. You can't give anything inside the gut. If you'll give, there is no use. It will just flush off outside inside the stool. Tetraglutide, it's oral LPG2 analog. It is a oral LPG2 analog. Tetraglutamide